Okay, so hello all, welcome. This new session is on the one-liners and mnemonics. So this session is FMGE 2022 must know one-liners and mnemonics for the subject of anatomy. I'm Dr. Ankit, MBBS MS, and your educator of anatomy in Unacademy platform. Let's start the session. So there are two components of the session. We'll have few one-liners, which are obviously pretty straightforward one-liners. But supplement that, we also will be having a small discussion of the few mnemonics which can help you in solving out many MCQs, right? So let's start the session over here. Okay, I hope, yeah, good evening, Rehan and others. Just a second, please. Better now. Okay, let's start the session. So few things, price hike is going from tonight, so you can use the code Dr. Ankit 10. There's a 6 months plus 2 month subscription. New subject wise going to start from tomorrow. From tomorrow, we also probably have a MBBS Prof 1 anatomy classes will be starting from tomorrow. So keep that in mind also. MBBS Prof 1. I'll just show you about that. For the free test calendar for FMG only. Launching the UPSC U.C.M.S. So UPSC exams have combined medical services. For that also we have a course for 1 and 2 months. That also you can see. And we have Prof 1 course 3, 6 and 12 months. You can use the code Dr. Ankit 10 for some discounts over here. These are the 4 or 5 type of subscriptions plus an iconic. I hope most of you are aware. It's Unacademy, Unacademy plus Prep Ladder. Light is mainly test series. This MBBS Prof 1 and the UPSC U.C.M.S. combined medical services. So these are few courses which are going on, few subscriptions. Let's come to the topic now. So there will be few one-liners and there will be few mnemonics. So one-liners I will rapidly go through it and kindly see whatever is written on the screen. And also kindly listen, and if you have anything notepad, you can note it down also few points which I will be telling along with the one-liners. Okay, mainly for anatomy subject over here. Let's start. So one line over here, knee joint being the largest joint. You should know the largest joint is the knee joint. The most complex joint is the knee joint. Knee joint is basically a modified hinge variety of joint. It is also classified as a bicondylar type of joint because there are 2 condyles of femur and 2 condyles of tibia. So various varieties, various sub-classification knee joint. But remember basic. It's the largest joint in the body, knee joint, not the ankle, not the hip, it is a knee joint. Other one-liner is typical ribs. Typical ribs are our 3rd to 9th rib, these are typical, so automatically the atypical ribs are the 1st, 2nd and 10th, 11th, 12th, those are atypical ribs. Some are basic typical ribs. Apart from typical ribs, remember the typical intercostal nerves are 3rd to 6th, these are intercostal nerves. So theoretically, these are the spinal nerves which are the thoracic part of the spinal nerve. So these are the thoracic spinal nerves. The typicals are T3 to T6. T3 to T6, these are typical. It means that T1 to and T7 to T12, they are not typical. They are atypical. So if somehow the question comes about the atypical, we should be knowing that what is atypical. Atypical is T1 to. Remember why? Because T1 is a part of brachial plexus. T2 forms the intercostal brachial nerve. And T7 to T12, they also supply the abdominal wall. These supply also, I mean that they will supply the intercostal spaces. But in addition to it, they will also supply the abdominal wall. So they are not typical. Typical are only T3 to T6. These are only the typical ones. Point clear? Next one liner over here. Nerve of Latarjet you must have seen in the stomach anatomy. Nerve of Latarjet, remember, is frequently asked question. It's a branch of the vagus that is the 10th cranial nerve. Remember that. And also the Arnold's nerve in the ear, external auditory canal. It's also a branch of vagus nerve. So the questions may come that okay, someone is washing the ear or clearing the ear canal and reflex cough due to the stimulus of Arnold's nerve. That is a branch of vagus nerve. Now with that, there can be another question. Kindly note it down. Jacobson's nerve. If they ask you Jacobson's, J-A-C-O-B, Jacobson's. Jacobson's is a basically 9th nerve branch, glossopharyngeal branch. Remember, glossopharyngeal branch, right? Now in the stomach also, like nerve of Latarjet in the stomach and around the celiac plexus. Remember a few points over here. What are those few points? Remember that when the vagus nerve starts from the medulla, we have a right and a left vagus nerve, but as you come to the stomach, there is an anterior vagal trunk and a posterior vagal trunk. Now, which is anterior? Right one becomes anterior, or is it a mixture? Remember, the left vagus nerve becomes anterior and the right vagus nerve becomes posterior vagal trunk. So these right and left are in the brain part, when they are coming out of the foramen magnum, and these anterior posterior are in the gut. So remember, anterior vagal trunk is basically has major components from the left vagus, and the posterior vagal trunk has major components from the right vagal nerve. Remember that basic point, right? Arnoldson already discussed. Jacobson's is a part of the ninth nerve. Remember that it forms the tympanic plexus in the middle ear. So that middle ear problem. Okay, so you can get a question like a patient had a tonsillectomy and there's a referred pain in the ear. So when you are removing the tonsil, in the bed of the tonsil, again you have this ninth nerve lying in the bed of tonsil. So that can be irritated, which can produce reflex pain from here into the ear. So that is also a question that can be frequently asked. Next, move to another one line, notochord. Frequently they ask you, the topic over here is embryological or you can say the germ cell germ layer derivatives. It's very important, but one of the frequent one-liners are notochord. It forms a nucleus pulposus. The various nucleus pulposus is basically in the intervertebral disc, the middle part of the intervertebral disc. So intervertebral disc has a nucleus pulposa in the center and outside it has a fibrous ring known as annulus fibrosus. This middle part is the nucleus pulposus. And if somehow they ask you a question that prolapse disc is the prolapse of this component. It is a cause of the prolapse intervertebral disc, nucleus pulposus. Remember that part. And the one liner we have this kindly noted down that very frequently asked over here, the testicular veins, where they drain. It's not just the testicular vein, but in females they can ask you the ovarian vein, right? So left testicular or left ovarian or left gonadal vein, same thing. They basically drain into the left renal vein of both the sexes, male or female. Remember this basic point. While in the right gonadal or right testicular, right ovarian vein, they drain directly into the IVC. Remember this. This is such a famous question. So they keep on asking you this. Now, in addition to this, they may add on over here that the left renal vein will also get contribution apart from the gonadal vein. They may get contribution from the left adrenal vein, left suprarenal vein, left adrenal vein. So that can also drain into the left renal vein. So left renal vein will get the left gonadal vein. It also get the left adrenal vein. It somehow may also get the left inferior phrenic vein. Not always, but yeah, at times it may get left inferior phrenic vein. So left renal vein is quite a bigger vein compared to the right renal vein. Remember that. Left renal vein is quite a bigger vein. And the question that may be asked to you is, this left renal vein, it crosses midline. It crosses the midline. Why? Because it has to drain to IVC. So why does it cross midline? Because IVC is on the right side. So left renal vein crosses midline. That's also one liner that you can keep a note of it. Next one liner, you can see over here that the dermatome of the small toe. So we have the toes, we have the great toe, the second, third, fourth, fifth. So this fifth toe over here, these are the nails. It is basically the S1. While the dermatome of the great toe over here is basically around L5. Remember that. So dermatome of the small toe is S1, and the great toe is around L5. So that is also helpful in various clinical tests for testing these spinal nerves. So L5 goes to the great toe and S1 goes to the small toe. Clear? Next one line over here, very important, frequently asked, lymphatic drainage. Because we have the ovarian tumors, we have the testicular tumors. Lymphatic drainage from the ovary or the testes is to the para-aortic or the lumbar group of lymph nodes. That is around the, imagine this is the aorta over here. So around the aorta there are few lymph nodes over here, para-aortic, and as we know the abdominal aorta is in front of the lumbar vertebrae. We also call it as a lumbar group of lymph node or para-aortic. So lymphatic drainage from the ovary and the testes also, not just ovary and testes also, they go to the lumbar or the para-aortic group of lymph nodes. Now that may create some confusion over here. What is that? That remember the testes are placed in a bag known as scrotum. Scrotum has a lot of layers. Inside you have this testes. Now lymphatic from the testes going to the para-aortic, fine. But what if from here if the scrotum skin or scrotum layers are involved? Lymphatic from the scrotum goes to the superficial inguinal lymph nodes. Superficial inguinal group of lymph nodes. That is a very important point which you should note it down somewhere. The testes lymphatics goes to the para-aortic, quite above and deep also. While the scrotal area, those lymphatics goes to the superficial inguinal group of lymph nodes. Superficial inguinal group of lymph nodes. Right? So remember this basic point. Again, a one liner important over here. Next couple of these over here. Phrenic nerve root value frequently asked. Phrenic nerve root value frequently asked. Remember C3, 4, 5. Now if suppose, though that would be a very rare thing to ask, but suppose all these are different options, A, B, C and D say C6. A, B, C, D, C3, 4, 5 and 6. And they ask you what's the root value of phrenic nerves. The best answer you have to pick out on these is the middle one, C4. That you have to pick it out, right? Phrenic nerve they ask frequently. Also they ask you the pudendal nerve also. Remember, in that case it is S234. So in that the middle one will be the S3, S234. It's pudendal nerve. Pudendal nerve, it does what? Remember, we have a pudendal canal in the perineum, in the ischiorectal fossa on the lateral side. There is a pudendal canal and then goes anterior into the urogenital triangle. So basically, this pudendal nerve is supplying what? It is supplying the areas in the perineum. It is basically supplying the perineum. Remember that. Even one of the branches of pudendal nerve is a perineal branch of pudendal nerve. Now this root value S234 is similar to a autonomic nervous system root value, that is the pelvic splanchnic nerve. So I am writing over here pelvic splanchnic nerve. Pelvic splanchnic nerve. What is that? Autonomic. Which autonomic? Sympathetic or parasympathetic? Think. This pelvic splanchnic nerve is a autonomic for sympathetic or parasympathetic? Sacral component. Parasympathetic is craniosacral. Okay. So this is our parasympathetic. The sympathetics are thoracolumbar. This is the parasympathetic, the pudendal nerve, S234. Fine. So these are frequently asked, the root values over here. Other root values can also be asked. One root value you can also remember is long thoracic nerve supplying the serratus anterior, C567. That can also be asked. Fine. Let's move on to another one-liners. Myelin sheath formation. Myelin sheath is covering around the axons. So if it is a nerve of a CNS, it is mainly by oligodendrocytes. All the nerves from the CNS, brain, spinal cord, which have a nuclei inside the CNS. Those myelin sheath are formed by oligodendrocytes, including the optic nerve. Why was optic nerve? Is coming from the optic stalk from diencephalon. That is also oligodendrocyte. While all the peripheral nerve systems, their nerves, the myelin sheath is formed by the Schwann cells. There the myelination is done by the Schwann cells. Remember, right? So Schwann cells and oligodendrocytes. Clear? Let's move on the forward. Yeah, masticatory muscles all are important, but just a one-liner over here that the lateral thyroid muscle is the masticatory muscle which helps in opening of the mouth or depression of mandible. You can ask you in a different part, like it also causes, because opening of the mouth is lowering down the mandible. It's the same as depression of mandible. So what are the other masticatory muscles? One is lateral thyroid, other is medial thyroid, then you have the masseter, then you have the temporalis. All these muscles, they help in closure of mouth. So why 3:1? It's not a good proportion. Only one muscle is helping in opening, others are helping in closing. The reason is very simple, that the mandible is meant for, or the muscles are meant for crushing or chewing the food. So you need more force while closing. So more muscles are there to close the mouth. Therefore grinding action. For opening you have the gravity plus a small muscle, lateral thyroid, and remember that opening of the mouth is not just lateral thyroid, but it is basically the muscles over here. What are these? Digastric muscles, mylohyoid muscles. So digastric muscles, DIGS, digastric muscles, the mylohyoid muscles, these are the main ones which help in opening of mouth. Lateral thyroid will help these muscles. So getting a point. So these are the muscles below the mandible, they help in opening of mouth, plus lateral thyroid, and obviously the gravity is always there to support in opening of mouth. Fine. So these are the muscles helping in closure of mouth. These will be helping opening of mouth. Luckily, all of them are supplied by a nerve known as mandibular nerve. That I guess is clear. Nerve of first pharyngeal arch, mandibular nerve, masticatory muscles. We'll come to more of it. Spinal cord ends at the L1 level in the adults or lower L1. They can, if L1 is not in the option, go with L2. Because it is lower L1 or L1 L2 junction. So normally they will give L1 as the option. If not L1, go with L2. But don't go at T12. L1 or L2. In children, it is slightly lower. It is around L3. Body of L3. Basic point, remember. Spinal cord ends. Spinal cord, right? Spinal cord. The lower end of spinal cord, we call it as? What is the lower point of the spinal cord? This point over here, what do we call it as? Is it chordae equina or conus medullaris? It is a conus medullaris. So the lowermost point is conus medullaris. Right? It is not chordae equina. Chordae equina are these rootlets coming out of the lower part from the horse's tail. These are the chordae equina. So when you insert the needle to take the CSF out in the lumbar region, your needle passes through the chordae equina roots and then suck the CSF out from there. Right? Needle goes around over here. It takes the CSF out from here. So conus medullaris is a part of the spinal cord, and cauda equina are these spinal rootlets. Clear? Let's see the other one. Winging of scapula, again, very, very famous question. Winging of scapula pressing against the wall, the medial border is becoming more prominent. That is due to the serratus anterior paralysis, basically long thoracic nerve damage leading to serratus anterior muscle paralysis. So remember this winging of scapula. Actually, it is a medial winging of scapula, but that becomes a little more complicated thing. But just remember, if the question is about the winging of scapula, the winging of scapula, it is serratus anterior muscle damage, long thoracic nerve damage, right? Then I ask you a question like this: long thoracic nerve is coming from where? Which part of this whole nervous system is giving us the long thoracic nerve? Remember, it is coming from the brachial plexus. Then which part of brachial plexus? The roots of brachial plexus. So this nerve comes from the roots of brachial plexus. Brachial plexus itself is an important topic. Just a one-liner over here from where it is coming. Let's move forward. Cubital tunnel syndrome. Cubital tunnel syndrome. Ulnar nerve gets trapped over there, may get damage over here. It's quite different from the carpal tunnel syndrome. The one which you all must have heard of a lot of times is carpal tunnel syndrome. Carpal tunnel syndrome is over here in front of carpals, median nerve. So carpal tunnel, if question is like this, it is basically referring to the median nerve compression, median nerve, right? But cubital tunnel is for the ulnar nerve damage. Right? There are a few other tunnels, but remember this. Tarsal tunnel will be for the tibial nerve, all those parts. That is different. But cubital tunnel and carpal tunnel frequently asked in the upper limb, ulnar nerve and median nerve. Move from here. Again, a part of brachial plexus has come again. Now, Ubbs palsy and Klumpke's palsy. Ubbs palsy, remember, is for when the upper trunk of brachial plexus is involved. What's the root value? C5 and C6. Okay. Klumpke's palsy, when the lower trunk is involved, what is the root value? Lower trunk is C8 and T1 mainly. Okay. Upper trunk, when it is involved, you have that potus man tip deformity, Vater's tip deformity. That is this Ubbs palsy, Vater's tip deformity. So don't get confused, Vater's tip deformity. How to remember? See, if you go through the alphabets of English, A, B, C, D, E, F, G, H, E comes before, then comes K. So first there is E, F, G, H, I, J, K. So E is the upper trunk, and then F, G, H, I, J, K, K is the lower trunk. Remember it like that. So when there is a Klumpke's palsy, then it is a lower trunk involvement. And Ubbs palsy is the upper trunk involvement. Ubbs palsy is this potus tip deformity like this. Klumpke's mainly involves the hand. There is a clawing of hand. There is clawing of hand. So Klumpke's is clawing of hand. And also that can lead to Horner syndrome because T1 is sympathetic. I told you thoracolumbar is sympathetic. So T1 is sympathetic. So it can lead to Horner syndrome. That is the involvement of sympathetics in the head neck region, right? So remember, Ubbs and Klumpke's very frequently asked, and brachial plexus itself is an important topic. Let's move on. Posterior triangle of neck. Neck triangles are important, obviously, but the most important triangle clinically and otherwise also is posterior triangle for MCQ purpose also. This is the sternocleidomastoid from mastoid to the sternum, and this is the trapezius. This forms a triangle over here, that is a posterior triangle of neck. Now, superficially running over here, just deep to the skin, is a spinal accessory nerve. So posterior triangle is basically formed by sternocleidomastoid on one side, trapezius muscle on the other side. And near the roof, you have this nerve which is running, that is a part of the 11th nerve, accessory nerve. There is a cranial component and a spinal component. There is a spinal component. This nerve supplies actually both the muscles, so it is running over there. So the big deal is, when you have a superficial cut over here, or suppose you went for a lymph node biopsy, or patient came to for a lymph node biopsy, you took the lymph node biopsy from where? From this deep cervical lymph nodes, and somehow, obviously, I call it as iatrogenic injury, but unwillingly you damage this nerve, the spinal accessory nerve. That can lead to, the question will come like the patient has a problem in combing his or her hairs. Because when you comb your hairs, you do a abduction of the upper limb that is going beyond the you can say the horizontal or the horizontal plane. So it is overhead abduction more than 90 degrees. So that creates a problem because these muscles, mainly trapezius, is used for overhead abduction, right? So that can be a question. The patient came to you with something and you did a lymph node biopsy, or there was abscess over here, you drained the abscess, and after some days the patient said, okay, everything is fine, but I don't know whether I should tell you or not, but I'm not able to comb my hairs as nicely as I used to. It's having some problem, I'm having weakness. That can lead to this. Okay, so these could be the sort of question that can be asked. Now, again over here, recently NEET PG also asked you questions regarding ligaments. Now, peritoneal ligaments the ventral dorsal mesogastrium mesentery derivatives, these are becoming important. There is a ligament between the spleen and the kidney known as lienorenal or splenorenal ligament. What lies in this ligament? See, ligaments are nothing, these are different from joint ligaments. These ligaments are double layer fold of peritoneum. So between these ligaments runs the splenic artery, and the tail of pancreas also lies over here only. So remember these two very important components of the lienorenal or splenorenal ligaments. There can be one more question, that these ligaments are derivatives of what? Okay. Yeah, obviously these will be available on YouTube, so no need to worry. These ligaments are derivative of dorsal or ventral mesogastrium. So these ligaments are derivatives of dorsal mesogastrium. Remember that. Okay. Dorsal mesogastrium. Let's move forward. Strongest ligament of the body is the iliofemoral ligament. Where is this ligament? In the hip joint, anteriorly, posteriorly, anteriorly. So anteriorly in the hip joint, you have a ligament known as the iliofemoral between the ilium part of the hip bone and the femur. That is regarded as one of the strongest ligaments in the body. And giving it a tough competition, giving this ligament a tough competition, is our intraosseous sacroiliac ligament. Sacroiliac ligament. Right? So intraosseous sacroiliac ligament is a close second, or giving a tough competition to this iliofemoral ligament. Right? So remember this. It is not quite as the strongest ligament of the body, the iliofemoral ligament. Right? These are the joint ligaments. Moving further, NLD. What is NLD? Is a nasolacrimal duct. You should know that where does it drain? Inferior meatus of the nose. Simple as that. Straightforward. Don't get confused. There can be questions like, what is the direction? Nasolacrimal duct, it coming down, fine. So it is direction is downwards. But apart from downwards, remember there are two other words like L and B. So when it is coming down, it goes laterally and it goes back. Remember this L and B also regarding the NLD. It goes lateral and backward. Obviously downward is downward. It's going from here to here. Medial canthus of eye to the inferior meatus. But also goes slightly laterally and slightly backward. Okay, so the direction of the NLD. Labyrinthine artery. Again, a frequent they can ask you questions like any inner ear problem. And you say Meniere's disease or say BPPV, problem in the inner ear artery or labyrinthine artery can be a question. Now, they may ask you it's a branch of what? It's basically a branch of AIC's anterior inferior cerebellar artery. This AIC itself is a branch of basilar artery. So if the question comes labyrinthine artery is a branch of, go with the first choice and the second choice. But this is not there, go with basilar. Labyrinthine artery is a component of internal auditory meatus. It goes through the internal auditory or internal acoustic meatus into the inner ear. See, labyrinth is inner ear. We have a membranous and the bony labyrinth. So basically it is inner ear only. Labyrinthine artery, mainly branch of AICA. If AICA not an option, then go with basilar artery. AICA is anterior inferior cerebellar artery, right? Move on further. Now gubernaculum. Gubernaculum is that fibrous sheath which is said to be pulling down the gonads in the intrauterine life. That is known as gubernaculum. So testes come down into the scrotum, but the ovaries, they don't come down. So the question may be coming as, what are the derivatives of gubernaculum in females? So in females, the gubernaculum derivatives are the round ligament of uterus and the ovarian ligament. These are two remnants of gubernaculum, and luckily both of them are a component or a content of a ligament around the uterus. Which ligament is that? Both are the content of a very important ligament around the uterus, that is a broad ligament. So both of these ligaments are a content of broad ligament, BROAD, broad ligament, right? Again, a one-liner like floor of femoral triangle, not the base. See, femoral triangle, if suppose I make this as a pubic symphysis, that is a pubic tubercle, this is the inguinal ligament, right? Not like this, it will go slightly above like this to the ASIS. Let me remove this, just a second. Very good, right? Okay. Oh, fine, right? So this is the pubic tubercle, that is the inguinal ligament going to the ASIS. This is the inguinal ligament. Now you have a muscle over here, adductor longus, and a muscle from here, sartorius. This forms a femoral triangle. Base is this inguinal ligament that forms a base. But the floor are these muscles. From medial to lateral, if you go, you have APPI. Most medial is the adductor longus. Most medial is the adductor longus, then more lateral to it, pectineus, then psoas major, then iliacus. Remember APPI. These are the floor. If they ask you the base, base is the inguinal ligament. Base is the inguinal ligament, right? So floor is APPI, adductor longus, pectineus, psoas, major, not minor, major, and iliacus. Clear? Femoral triangle, another very high topic, obviously, on the lower limb part. Let's move further. Now, trigeminal sensory map. Our whole phase, the sensory supply comes from the trigeminal nerves, V1, V2, V3, except the area around the parotid region, and that is supplied by a branch of cervical plexus. Remember, that is frequently asked. This area over here, around the angle of mandible, they may give you, like in the question, or around the parotid region. There the sensory nerve supply, sensory, not motor, sensory nerve supply over here is greater auricular nerve. That is coming from the cervical plexus, having root value of C2 and C3 over here, right? So apart from this area, everywhere else is V1, V2, V3, ophthalmic, maxillary, and mandibular nerve. Clear? Let's move further. Frequently asked question you all must be knowing. Coracoid process of scapula is a example of atavistic epiphysis. Frequently asked, lot of time. Just a one-liner over here. Then cords of Billoth again is small found in the splenic histology. Spleen, you mainly have the red and the white pulp. Red pulp forms the bulk. In red pulp, we have this things known as cords of Billoth. Remember, this can be a straightforward question that will help you. Then you have this skin between the first and second toes. If we just draw like the foot over here, having the great toe, the second, third, fourth, fifth, like this. You have the nails over here. The area over here, the skin over here, only over here, that is sensory innervated by deep peroneal nerve. Rest majority of the dorsum of the foot is superficial peroneal nerve. Which nerve? Superficial peroneal nerve. Only the small area around the great toe, first and second toe, that is sensory innervated by the deep peroneal nerve. Rest area is superficial peroneal nerve in the dorsum of the foot, not plantar aspect, not on the sole, on the dorsum, that is on the upper surface of the foot. Remember this. Frequently asked question. Then from the coronary arteries, they may ask you like LED. What is LED? Most commonly involved artery in your atherosclerosis, MI attacks, angina. Left anterior descending artery. It runs where it runs. It is also known as anterior interventricular artery. Runs where? In the anterior interventricular sulcus. Remember these basic points. LED and AIV are same. It's basically a branch of LCA, left coronary artery. Remember, LCA is bigger than RCA. Remember this. LED is most commonly involved. Second question, in the conducting system, because when there is a arteries involvement, it could lead to arrhythmias. Why? Because these arteries supply the conducting system. In the conducting system, we all know we have SA node, AV node, then bundle, then Purkinje fibers, all those. So the proximal part of the conducting system, basically the SAs and the AV nodes, they are basically supplied mainly 60-70% or 70-80% by the right coronary artery, RCA. And the distal part of the conducting system, mainly the Purkinjes and the bundle of his, all those are supplied by mainly by LCA branches, mainly this LED only, right? So remember that basic point. Next, CPN. What is CPN? CPN is common peroneal nerve. CPN, we have a sciatic nerve, remember, which divides into CPN, common peroneal, and a tibial nerve. Fair enough? Okay, then the CPN is going to divide into superficial peroneal nerve and a deep peroneal nerve, right? Fair enough, that is basic. The CPN is quite superficial. It is close to the neck of fibula, and it is literally subcutaneous nerve, where it winds around the neck of fibula. Therefore, it is the most commonly damaged nerve in the lower limb. It is winding, it is subcutaneous, plus second, it is outside, meaning why? It is laterally. So if there is any injury on the outside in the lower part of the knee joint, on the lateral aspect, it can injure this nerve, right? CPN is the most commonly damaged nerve in the lower limb, From the thorax part, some other one-liners like over the hilum of the right lung. Now these in the INICTs and NEET PGs, FMGEs, the hilum of the lungs are also nowadays frequently asked. Remember, over the hilum of the right lung, there is an arch of azygous vein. The veins are normally on the right side. While over the left lung hilum, you will have the arch of aorta. Aorta is on the left side, veins are on the right side. Simple, basic rule. So arch of azygous vein is on the right side over the hilum. So remember, this is the hilum of the lung. Then arch of azygous vein goes like this. If it is the left side, then arch of aorta, right? Second thing is nerve anterior to this hilum, nerve running over here is phrenic nerve. Anterior to the hilum is phrenic nerve, and posterior to the hilum, if the nerve is going close to the esophagus, posterior to the hilum, it is the vagus nerve. Remember that, because vagus nerve supplies the gut, so it runs along with the esophagus, and esophagus lies posterior. So anterior nerve is phrenic, posterior nerve is vagus. Over the hilum, azygous on the right side, left side, arch of aorta. Clear? Move forward. AIN, PIN. AIN, PIN are what? These are the anterior and the posterior interosseous nerves in the forearm. Anterior interosseous nerve and the posterior interosseous nerve. Simple as that. Remember, AIN is a branch of median nerve, straightforward. PIN is a branch of radial, straightforward. PIN passes through the supinator muscle. Supinator muscle, right? Supinator muscle. Then goes supply the posterior muscles or posterior forearm muscles. AIN will supply the flexor muscles, but the deep flexor muscles. What are those deep flexor muscles? These are your flexor pollicis longus, these are pronator quadratus, and these are the lateral half of flexor digitorum profundus. Flexor digitorum profundus. So flexor pollicis longus, pronator quadratus, and lateral half of flexor digitorum profundus. AIN, anterior interosseous nerve. Let's move on further. PCA. PCA is what? PCA is posterior cricoarytenoid muscle of the larynx. It is posterior cricoarytenoid muscle. So posterior cricoarytenoid muscle. Right? It is the sole. Sole means it is the only abductor of vocal cord. Only abductor of vocal cord. Rest, all the other muscles are either adductor, or they will change the tension of the vocal cord, or they may help in opening or closing of the laryngeal inlet. But the only muscle opening the vocal cord is just one, that is posterior cricoarytenoid. Safety muscle of larynx also known as, right? Supplied by recurrent laryngeal nerve. So this PCA is supplied by the recurrent laryngeal nerve. Fine. Let's forward. Tongue muscles are supplied by 12th nerve. Simple as that. Straightforward. Except there is an exception, which is the palatoglossus. It's actually also a muscle of the palate that is supplied by the pharyngeal plexus. Pharyngeal plexus. Other tongue muscles by the 12th nerve. But one more point I just wanted to add, that when you taste anything in the anterior part of the tongue, the taste from the anterior part of the tongue is carried by the chorda tympani nerve, which is the branch of facial nerve. And from the posterior part of the tongue, the posterior part of the tongue, the taste or the sensation are carried by the 9th nerve. Remember. Taste from anterior part of tongue is chorda tympani. Taste from posterior part of tongue is glossopharyngeal nerve. Remember this point. And muscles are supplied by 12th nerve, hypoglossal nerve, except this muscle, palatoglossus. It's also actually a muscle of the soft palate that is supplied by the pharyngeal plexus. Point clear? Move forward. Killian's dehiscence, frequently asked. Killian's dehiscence. Killian's dehiscence over here is a small, this dehiscence means weakness in the wall. It is in the larynx, it is in the pharyngeal muscles close to the larynx part, between the cricopharyngeus and the thyropharyngeus. Both are parts of which muscle? Inferior constrictor. Inferior constrictor. Remember this. Clear? Killian's dehiscence over here. Move forward. I already told you. The facial muscle supplied by the facial nerve, which is the nerve of the second pharyngeal or branchial arch. Sensory by the trigeminal nerve, we already discussed. And which area, except which area? Around the parotid region. Which nerve was supplying this? Great auricular nerve or great auricular. Very important point. Around C6 level, vertebral level, the trachea and esophagus starts. It means that C6 level, the larynx and pharynx, they end. Because trachea is a continuation of larynx. It's a continuation of larynx. And esophagus is a continuation of pharynx. So these two structures, they end at C6. And the trachea esophagus will start at C6. Basic idea. Phrenic nerve, it was running anterior or posterior to the hilum. It was running anterior to the hilum of the lung. So it is basically running between the pericardium and the mediastinal pleura. So it is actually lying in the middle mediastinum. Remember this. You have a heart covered by pericardium, and the side of which you have the phrenic nerve running. So it is a content of middle mediastinum. While a vagus nerve runs posteriorly, posterior to the heart in the esophagus. So vagus nerve is a content of posterior mediastinum. Remember this point. Clear? So phrenic nerve, two things, anterior to the hilum and middle mediastinum. Vagus nerve posterior to the hilum and posterior mediastinum. Apart from this, remember these two nerves are coming from above. So these two nerves, they both are also content of superior mediastinum. Just in case they don't give options like these, both of them, phrenic, vagus, are a content of superior mediastinum. Clear? Broca's area, Wernicke's area. Frequently asked. Broca's area, motor speech area. Lying where? Inferior frontal gyrus. What is the Broadman's number? 40 or 45. Motor speech area. Wernicke's area, sensory speech area. To comprehend the spoken language. Where it is lying? Superior temporal gyrus. Broadman's number is around 22. If they ask you the complex, then it is 22, 39, 40. But only Wernicke's area is 22. Fine. MCA is what? Middle cerebral artery. The biggest branch of internal carotid is middle cerebral artery. The biggest cerebral artery is middle cerebral artery. The middle cerebral artery is very important artery, but it does not form a part of the circle of Willis. Circle of Willis is contributed by anterior cerebral, posterior cerebral, anterior communicating, posterior communicating, but not middle cerebral artery. Remember that point. PCOM is posterior communicating artery. Posterior communicating artery. It is a branch of internal carotid artery. Clear? So the point over here is written that PCOM artery, posterior communicating artery, connects anterior to the posterior circulation of the brain. So we have an anterior circulation of the brain, that is basically ICA. We have a posterior circulation of the brain, basically that is vertebrobasilar artery. Right? So what is connection between the anterior and posterior circulation? Is this posterior communicating artery. That is a branch of internal carotid artery. Remember this. Clear? Let's see forward. Adduction of the thumb. Muscle is adductor pollicis. Thumb lies laterally, but this adductor pollicis is supplied by the deep branch of ulnar, very frequently asked. Adductor pollicis. All the other pollicis muscles like abductor pollicis, flexor pollicis, opponens pollicis, those are supplied by the median nerve mainly. But this adductor is an exception. So remember that. Same ways, if you look at your foot, then your great toe lies medially. Great toe lies medially. Here the thumb is lying laterally, but in the foot the great toe is lying medially. So here, there we have the hallucis. So same case, they can ask you adductor hallucis. So in the foot or the sole of foot we have nerves like plantar nerves, medial and lateral plantar nerves. So great toe lying medially, this muscle in the foot should have been supplied by the medial plantar nerve. But again, like the upper limb, they have an exception. This muscle is supplied by the lateral plantar nerve. Remember this? Adductor pollicis, adductor hallucis. Pollicis and hallucis. Now, ventral dorsal, I already told you in the questions that the mesogastrium, they are asking a lot of times this ventral dorsal mesogastrium. So remember that there is a mnemonic known as VDRL. You can remember this. That ventral mesogastrium derivatives are to the right of the gut. The dorsal mesogastrium derivatives are to the left of the gut. Meaning by what? What does it mean is that this is supposedly the esophagus and that is the stomach. Esophagus and stomach and duodenum, right? Foregut part. Any peritoneal derivative lying to the right is a derivative of ventral mesogastrium. What are these? Lesser oventum, falciform ligament, ligaments covering the liver. All these are derivatives of ventral mesogastrium. Any ligament lying to the left of it is a derivative of dorsal, like greater oventum, spleno-renal ligament, gastrosplenic ligament. Then you have the gastrophrenic ligament, phrenicocholic ligament, everything to the left of it. So these are all ventral derivatives, these are all dorsal derivatives. Why? Because this foregut turned 90 degrees to the right. So ventral structures went to the right and the structures which were behind came to the left. So it's simple. Clear? Move forward. Cystic artery supplying the gallbladder, obviously most important while doing cholecystectomy. Video open, video laparoscopic. You have to identify cystic artery. You should know anatomically it's coming from where, because if you are not able to see the artery, look at its parent branch, right hepatic. If you're not getting this, look at its parent branch, the proper hepatic. So go to the hepatics, search for the right and left hepatics. For right hepatic should be giving the cystic artery. Okay, cystic artery branch of right hepatic. Pin structures. Pin structures, they wind around the ischial spine of the pelvis. So what are these pin structures? Now these pin structures are the three structures over here. These are your pudendal nerve, internal pudendal vessels, and nerve to obturator internus muscle. These three structures, they wind around the ischial spine. So they lie in the greater sciatic foramen as well as the lesser sciatic foramen. Though this nerve does not lie totally, but you can assume it for the time being. These pin structures, they lie in the greater sciatic foramen. Then they wind around the ischial spine, then they go into the perineum. So they also are a content of lesser sciatic foramen. So both the sciatic foramens should know these pin structures. And questions come like pudendal nerve. You give a pudendal blocks in obstetrics, and the landmark is the ischial spine. For pudendal nerve block, the landmark is the ischial spine. That is also another question. Moving forward, popliteus muscle. The popliteus muscle is a muscle of the which compartment of leg? Muscle is a muscle of the posterior compartment of the leg, a deep posterior compartment of the leg. The tendon of popliteus muscle is the only tendon in the lower limb which is intracapsular. Another point, intracapsular. The popliteus muscle helps in unlocking of the knee joint. So there is a locking, unlocking. There is locking, there is unlocking. Locking is medial rotation of femur, and unlocking is the lateral rotation of femur. So remember, the popliteus muscle is responsible for the unlocking. Clear? Let's move forward from here. Other one-liners. GSV. What is GSV? It is not GST, it is GSV. Great saphenous vein. SSV is short saphenous vein. So great saphenous vein runs with the saphenous nerve. Recently, NEET PG, they asked you this, so it becomes a high yield point. Both are subcutaneous. It is a cutaneous vein, it is a cutaneous nerve. The saphenous nerve is a branch of femoral nerve, remember, femoral nerve. And where does it lie? Medially or laterally? Great saphenous vein and saphenous nerve, where do they lie? In the leg. Medial, lateral, they lie medially. The short saphenous vein, which is lying laterally and posteriorly, runs with the sural. So they are lying laterally as well as they go posteriorly also. Remember this basic point. The question which they asked in NEET PG was, there was varicose vein surgery done, and around the saphenofemoral junction, and then the patient had some altered sensation in the medial part of the leg. Which nerve is involved? Saphenous nerve. Straightforward question. Then we have, I told you this already, gave you a hint of it in discussing the adductor pollicis and adductor hallucis, that medial plantar nerve in the foot has the same distribution as the median nerve in the hand. So you can remember it by M&M. Medial plantar nerve in the foot has the same distribution, more or less same, in the hand only, not in the whole upper or lower limb, no. Only in the hand region or in the foot region, the medial plantar nerve is similar to median nerve, while the lateral plantar nerve is similar to ulnar nerve. So if they ask you that, which is the dominant nerve in the foot? The dominant nerve in the hand is, the musician nerve in the hand is, musician is ulnar nerve. So the dominant nerve in the foot will be lateral plantar. Clear? It supplies more muscles in the foot. Clear? This question again important, that the superior gluteal nerve, you must have seen questions like the Trendelenburg test and all. The superior gluteal nerve supplies the gluteus medius and minimus muscle. If these are damaged, then there is a Trendelenburg sign positive. The opposite hip drops. Opposite hip that drops while walking. So suppose the right side superior gluteal nerve is damaged. So when I am walking and I take my left foot off the ground, the left side of the pelvis, that will drop down. Opposite. Inferior gluteal nerve will supply the maximus. Maximus is basically the chief extensor of the hip joint. Chief extensor of the hip joint. So that will weaken, right? So remember this, and this is also important. Key muscles, if they ask you a single one-liner, that in the gluteal region, the key muscle is piriformis muscle. And in the axilla, the key muscle is pectoralis minor. This pectoralis minor is going to divide the axillary group of lymph nodes. It is going to divide the axillary arteries also. That is form the key muscle. Clear? What is DIR-SIR? DIR-SIR is deep inguinal ring and superficial inguinal ring in the inguinal canal anatomy. Okay. So deep inguinal ring is a defect in the fascia transversalis. Stop. Superficial inguinal ring is a triangular defect in the external oblique aponeurosis. That's it. Keep it simple. Deep inguinal ring is the entry point, said to be the entry point of the canal. Superficial inguinal ring is said to be the exit point of the canal. The entry and exit of the canal. Clear? Let's move forward. Tongue licks the wound. That is simple. What is that to do with anatomy? Meaning by, suppose I have a wound over here, my tongue like this, right? It tells us that if there is a left hypoglossal nerve injury, so when you ask the patient to protrude the tongue will go to the left side, right? So tongue deviates to the side of the hypoglossal nerve injury on protrusion. That you can remember it by the mnemonic that tongue licks the wound. The tongue goes to the right side on protrusion. It is a right hypoglossal nerve injury. So this point you should know. Pyruvate fossa, it's a component of what? It's component of pharynx, the hypopharynx or the laryngopharynx. Pyruvate fossa, they can ask you like smuggler's area, also known as. What is the sensory innervation of this pyruvate fossa? It is an internal laryngeal nerve, not the recurrent. It is the internal laryngeal nerve, right? Pyruvate fossa, anatomy is important. Next one. In the histology, they can ask you like demilunes, serous demilunes or simple demilunes. Demilunes are seen in the mixed salivary gland, mainly the submandibular salivary gland. That can be another one-liner. Costochondral joint, the joint between the ribs and their costal cartilage is basically a type of primary cartilaginous. A whole thoracic cage, all these joints are important. The manubrious tunnel, the Ziphius tunnel are the secondary cartilaginous. Then the sternocostal joints are your synovial, except the first one, which is primary cartilaginous joint. All those, so thoracic cage joints, if you see my thoracic classes, thoracic cage, you will get to know all those varieties. But this frequently asked, so we just place this. Next we have this glans penis, the most distal part of the penis that dives into deep inguinal group of lymph nodes, just a one-liner over here. We also have genioglossus. This is the muscle that helps in protrusion of the tongue. So when you sleep, the tongue does not fall back, so it is known as the safety muscle, and it is the bulk of the tongue. The main bulk of the tongue is by the genioglossus muscle. The nerve which supplies it is the hypoglossal, not the palatoglossal, the hypoglossal, because all the muscles of tongue by hypoglossal except the palatoglossus. Larynx again has three unpaired cartilages. Three paired are arytenoid, corniculate, cuneiform, ACC. Three paired are ACC, arytenoid, corniculate and cuneiform. And three unpaired are your epiglottis, the thyroid and the cricoid, etc. Okay, so total 9 cartilages, 6 and 3, 9. Hyoid bone, as in last day INICT, seems to be very close to larynx, and it is very close to larynx, but it is not a part of larynx. Larynx is basically cartilages. It is a bone. It's a separate bone. Remember this. Frontal plane, now very basic thing, but yeah, frontal plane, coronal plane, dividing the body into anterior posterior parts. Coronal plane we all know, but that is also known as a frontal plane, frontal section, frontal plane. Remember that. Clear? Now let's come to some quick mnemonics over here. These are the few one-liners. I hope if 2-3 questions come from the one-liners, it would be really glad for your time investment. Now a quick go through some of mnemonics over here that will help you. Scalp nerve supply. Remember the mnemonic is glass over here. Glass, what is glass? It is a greater occipital, greater auricular, lesser occipital nerves. So these are the upper 3 are the nerves of cervical plexus. This ASS is auriculotemporal, supraorbital and supratrochlear nerves. These are branches of the trigeminal. So remember the glass, that may help you in remembering the sensory nerve supply of the scalp, not the face. Face has different. This is only the scalp. Second mnemonic over here is the cavernous sinus contents. Contents of cavernous sinus. Mnemonic is O tomcat. Okay, here you can see T twice, so it is the same thing, O tomcat. What is this? You can either remember like third, fourth, 3, 4, V1, V2 lies on the lateral wall. This is the third nerve, oculomotor. This is fourth nerve. V1 is ophthalmic nerve. V2 is maxillary nerve. C is the carotid artery, which is the internal carotid artery. A is the sixth nerve, abducens nerve. Okay, T is a similar over here, just repetition. So these 3, 4, V1, V2, they normally lie in the lateral wall of the cavernous sinus, and these 2 are there in the inside, the content of the cavernous sinus. The artery along with the sympathetic plexus and the abducens nerve, right? Now, all of these are part, but V2 may or may not be. So this is plus or minus V2. V2 may be slightly outside the cavernous sinus also, slightly outside, but very close to the cavernous sinus. Next mnemonic over here, deep cerebellar nuclei. Okay, the mnemonic was, if I remember, the fat guys eat donuts. Okay, donuts high in calories. So it is from medial to lateral, the fastigial, the globose, emboliform and dentate nucleus. So when the most lateral is a dentate, and that is most medial is the fastigial. Most medial is the fastigial nucleus, and the largest nucleus is the dentate. You must have heard of tracts like dentatorobrothalamic tracts. So dentate nucleus, crumpled bag appearance, it may give you an appearance like this, nucleus going laterally outside dentate, then one more dentate over here. Then you have this emboliform, then globose, then fastigial, emboliform, globose, fastigial, like this. So most medial is the fastigial, most outside is the dentate nucleus. The biggest is the dentate, crumpled bag appearance. Next thing over here, hand intrinsic muscles. Hand intrinsic muscles. Mnemonic is this. What are this? All for one and one for all. All for one and one for all, if you can remember it. So these are for the thenar, these are for the hypothenar muscles. 2A, so one is abductor and one is adductor. F and O are flexor and opponens, pollicis. Flexor, opponens. Same over here in the hypothenar part, opponens, flexor, and this will be your abductor. Abductor digiti minimi. Opponens digiti, flexor digiti, and abductor digiti minimi. Here one is missing, hypothenar also we have 4 muscles, one is missing, which is that is a superficial muscle of the hypothenar, that is palmaris brevis. So you can add over here, this also you can have a palmaris brevis over here. Just a small mnemonic, if this helps you, all for one and one for all. So abductor, flexor, opponens and adductor pollicis. And these are opponens, flexor and abductor digiti minimi plus palmaris brevis, so total 8. Okay. Then ECA branches, external carotid artery branches. Okay. These are your mnemonics, SALF, OPMS. So 7 angry ladies fought over PMS, or you can make a mnemonics. But the sequence is important. Why? There are 8 branches. So you can see 1, 2, 3, 4, 5, 7, 8 sequences from initial branches to the distal branches, proximal to the distal branches. This S is the superior thyroid artery, the first branch. Then A is the ascending pharyngeal artery, which is the only medial branch. L is the lingual artery, anterior branch, facial artery, anterior branch. These are all anterior branches. Opposite to facial, occipital artery, that is running posterior. Above occipital is the posterior auricular artery, that is also running posteriorly. And M and S are the terminal branches, the maxillary artery and the superficial temporal artery. These are the 2 terminal branches. So remember, the superior thyroid, lingual, facial are the anterior branches. These three are the anterior branches. Okay, these 3 are the anterior branches. The posterior ones are the occipital, posto-auricular. The only medial is ascending pharyngeal artery, and the terminal branches are maxillary and superficial temporal. 7 angry ladies fought over PMS, and make a mnemonic. But the mnemonic over here is important to tell you the sequence. This is the first branch, which comes the last one, and like this. Then we have a diaphragm. The openings and diaphragm very important. I8 is your IVC is at the T8 level, IVC opening. 10E is at the T10 level. You have the E is for the esophageal opening. A12A is for the aorta, and 12 is the T12 opening. So how to remember is I8 10 eggs at 12. Yeah, I8 10 eggs. High protein diet. I8 10 eggs at 12. So all the other mnemonics like also vena cava is 8 letter, esophagus is 10 letter, 10. So there are various mnemonics, just a way to go through it. IVC is a T8, esophagus and aorta. In addition, remember IVC along with IVC is the right phrenic nerve that passes along with IVC. Along with the esophagus are the vagus nerves that are passing. Along with the aortic opening, you have the thoracic duct and the azygous vein which passes along with the aortic opening. So that can also help you. Radial nerve, what does it supply? The trunk of radial nerve. The trunk of radial nerve. Best muscles. Best. B refers to brachioradialis. B refers to brachioradialis. That is supplied by the radial nerve. E is your ECRL, extensor carpi radialis longus. Right? S is the supinator over here, and T is your triceps. T is your triceps. Okay, these are the muscles supplied by the radial nerve trunk. Okay, though supinator may also be supplied by posterior interosseous, but mainly muscles are these. Brachioidalis and also the lateral part of brachialis also. Lateral part of brachialis also is supplied by the radial nerve. So remember that. Musculocutaneous BBC. Musculocutaneous nerve is the nerve which supplies the anterior arm muscles. BBC refers to biceps, brachialis and coracobrachialis. I repeat again. Musculocutaneous nerve supplies the anterior arm muscles. Biceps, superficial, deep to it, brachialis, and going medially is coracobrachialis. The cutaneous part of it is lateral cutaneous nerve of forearm. Lateral cutaneous nerve of forearm. Forearm, not arm, forearm. That is also a question, right? Musculocutaneous nerve. Median nerve, what does it supply in the hand? Hand, remember, if you remember, one for all and all for one. It is one for all. Opponents, abductor and flexor, not adductor. Adductor pollicis was supplied by ulnar nerve. What is this L over here? L is the lumbricals, the first and the second lumbricals. The first and the second lumbricals. Clear? One for all is going to help you over here. One for all and all for one. So loaf, median nerve supplies these muscles in the hand region. Let's move forward. Serratus anterior. What is salt over here? Serratus anterior, winging of scapula. LT is long thoracic nerve. Remember salt, namak, NaCl. Serratus anterior, long thoracic nerve. Simple as that. Serratus anterior, long thoracic nerve coming from the roots of brachial plexus. Let's see others. Pectoral nerves. Two pectoral nerves are there. One is the lateral pectoral, one is the medial pectoral. Lateral is less. What does that mean? Medial is more. Meaning by the medial pectoral nerve supplies both the pectoralis major as well as minor. So it is more. It supplies more muscles. The lateral is less. Lateral will only supply the pectoralis major, not the minor normally. So lateral is said to be less. L for lateral, L for less. So if they ask you which supplies the P minor is by the medial pectoral nerve. Medial pectoral nerve. Lateral pectoral nerve will only supply the majors. Basically, major supplied by both, but minor only by the medial pectoral nerves. So you can remember it by medial more, so it supplies minor also. Next one, axillary artery branches. Send the lady say prayers like this and mnemonic over here. Axillary artery, I told you, axilla, the key muscle was P minor. Key muscle was P minor. So P minor divides the axillary artery into first part, second part and third part. First part has only one branch, S for the superior thoracic or supreme thoracic artery. This branch from the first part. Second part has two branches, T and L. T for the thoracoacromial artery, and L is for the lateral thoracic artery. Third part of the axillary artery has three branches, S, A and P. S is the largest branch, subscapular artery. A and P are anterior posterior circumflex humeral artery. Anterior posterior circumflex humeral artery. S is subscapular artery, lateral thoracic, thoracodorsal and supreme thoracic or superior thoracic artery. And the lady say a prayer. The axillary artery branches, key muscle was P minor. That is important. Let us see more. Thoracoacromial, the same artery which you saw over there, thoracoacromial, it is a trunk actually. It gives off few major branches, APCD, not ABCD, it is APCD. Remember that erase this part from the B, it becomes P, right? Half of B is P. So APCD are the areas over here, acromial, pectoral, clavicle, deltoid, same. APCD are acromial branches, pectoral branches, clavicular branches, the deltoid branches. Thoracoacromial divides into these branches. Elbow anastomosis. Now, topic is elbow anastomosis, of the anastomosis of arteries around the elbow region, around the cubital fossa region. I am pretty smart. Okay, what does that mean? See, there are various arteries over here, but on the medial side of the elbow, you have an artery running anteriorly known as inferior ulnar collateral artery and artery running posteriorly known as the superior ulnar collateral artery. So, artery running anteriorly is inferior ulnar collateral artery. Running anterior. Artery running posterior is superior ulnar collateral artery. That was the point. Artery running with the ulnar nerve. Artery running with the ulnar nerve. Now, ulnar nerve is anteriorly or posteriorly? You should know. It is lying behind the medial epicondyle. So artery running with the ulnar nerve is superior ulnar collateral artery. Okay. Inferior ulnar collateral artery is also known as, also known as supratrochlear artery. That also you can note it down somewhere. Is also known as supratrochlear artery. Just this point. Clear? Let's move forward. PDN, I hope you guys know this mnemonic. Palmar interossei are adductors of the fingers. Adductors. This is palmar interossei. Dorsal interossei are abductors. Dorsal interossei are abductors. Palmar interossei are adductors. Okay, pad and dab. Interossei muscles. All these palmar dorsal interossei are supplied by ulnar nerve. It is a key muscle, or sorry, the key nerve, or the important, or the dominant nerve in the hand. And what was the dominant nerve in the foot? Lateral or medial plantar nerve. It was a lateral plantar nerve in the foot. It is similar to ulnar nerve in the hand. Clear? Lady between two majors. Lady over here is not a lady, but LD is latissimus dorsi muscle. So there is a latissimus dorsi muscle which is between two majors. Outside you have a pectoralis major, and inside medially you have a teres major. Teres major. In between them you have this latissimus dorsi muscle. These are three muscles. Talking of the attachments at the bicipital groove. Clear? P major lying laterally, T major lying medially, and ladies between. Clear? Rotator cuff muscles around the shoulder joint capsule. SITS sits. Supraspinatus, infraspinatus, subscapularis, and T is small letters because it is teres minor, not major. It is teres minor. The small t refers to teres minor, minor. SITS, supraspinatus, infraspinatus, teres minor. The last S is subscapularis. Let us see more over here. Cubital fossa contents from medial to lateral. Fossa contents. Most medially is, this is medial to lateral, is M for median nerve. Then you have the two B's. First will come the artery or the tendon. There is a brachial artery and a biceps tendon. First will come the brachial artery. Then comes the biceps tendon, and most laterally is the radial nerve. Most laterally is this radial nerve over here. I repeat again, median nerve and radial nerve. Between them you have an artery first, then go more laterally, biceps tendon. You can actually palpate the brachial artery. You must have taken the blood pressure of the patients. So if you slightly flex your elbow, you feel the tendon, and just go medial and then straight and extend the elbow. Your fingers are over the artery. Okay, so remember this cubital fossa contents. Inversion muscles of the foot. Now what is inversion muscles of the foot? Let us see. What are the inversion? Now inversion of the foot is done by tibialis, both anterior and posterior. That does what? It does inversion of the foot. Agreed? Eversion of the foot is done by peroneus. There are various peroneus like peroneus longus, peroneus brevis, peroneus tertius. What they do? They do eversion. Clear? Yes. So what is second letter? I is the second letter in tibialis. E is the second letter in peroneus. So just for remembrance, I refers to inversion. E refers to eversion. Second letter. Okay. That can help you in remembering. In the exam, all these small things, they may become important, right? The second letter in tibialis is I, meant for inversion of foot. And second letter in peroneus is E, meant for eversion of foot. Thigh innervation. Now this is a map. MAP, map of S refers to any country, say Sri Lanka. What does that mean? Thigh innervation map. MAP, map of OFS, say any country, Sri Lanka. M is what? M is the medial compartment of thigh, obturator nerve. A is the anterior compartment of thigh, femoral nerve. P is the posterior compartment of thigh. S is the sciatic nerve. Basically, it has a branch, mainly the tibial nerve, or tibial branch of sciatic nerve. Okay, but this is the point, right? So, map of Sri Lanka. Thigh innervation. Subsequently, over here, the leg also, if we say anterior, posterior, and lateral compartment, the leg. Anterior is by the deep peroneal nerve, posterior by the tibial nerve. That is same, lateral by the superficial peroneal nerve. So remember that also in the leg. This is for the leg. This mnemonic is for the thigh. Fine. Let us see more. Femoral triangle contents. I told you femoral triangle floor. APPI. This is contents from lateral to medial. Most lateral is the nerve, then comes artery, then comes vein. Then there is an empty space known as, E for empty, known as femoral canal, which has a L for lymph node, a lymph deep node of Cloquet or Rosenmuller. Right. Nerve lies outside the sheath. These are all inside the femoral sheath. So nerve is most laterally, then artery, then vein, then empty space femoral canal. Inside you have a lymph node. Remember this, from lateral to medial. Right. Medial wall of orbit, orbital walls. This is again going from anterior to posterior. My little eye sits in orbit. This is just the bones. You can remember it if you wish to. Maxilla, lacrimal, ethmoid and sphenoid. MLES. MLE exam, USMLE. Remember from there, MLE. NS is the sphenoid. Sphenoid part over it is the body of the sphenoid. Right? Maxilla, lacrimal, ethmoid and the body of sphenoid. These are the medial wall of orbit. One of the most common. The thinnest wall of orbit, quite easily damaged. Anterior to posterior. Mandibular nerve muscle innervation. I told you already, masticatory muscle supplies all the masticatory muscles. What are those masticatory muscles? We have seen that lateral pterygoid, medial pterygoid, the masseter and the temporalis. Fine, that we know. Apart from this, supplied 4 other muscles. MAT over here, M refers to the mylohyoid muscle. Okay. A refers to anterior belly of digastric. Both T are tensor tympani and tensor palatini. This is MAT, M-A-T-T. Apart from the 4 masticatory muscles, it supplies mylohyoid, anterior belly of digastric, tensor tympani and tensor palatini. And all of these are supplied mandibular nerve, which is a nerve of first pharyngeal arch. So these are all first pharyngeal arch muscles. Let's move forward. Extraocular muscles, we all should be knowing. Superior oblique by the 4th nerve, lateral rectus by the 6th nerve, rest all the extraocular muscles by the 3rd nerve. Right? Rest all the extraocular muscles by the 3rd. Here's a small of the actions, sit in red. The muscles, if you see, there are 6-7 muscles. Confusion arises in superior rectus, superior oblique and inferior oblique actions. But there are more than one actions. So remember, the superior muscles out of these two will cause intorsion of the eye. Intorsion is this movement, rotating inward. It means that the inferior muscles are causing extorsion outside. The recti over here, meaning by these two recti, they cause adduction. AD is adduction of the eyeball. Adduction. Meaning by the obliques will cause abduction of the eyeball. So this will help you in remembering their actions also. In their actions. Sit and rad. SITRE. Celiac trunk branches. Celiac trunk is a artery supplying the foregut. Right? Mainly 3 branches are there, known as left hand side. What is left hand side? Is left gastric artery, the hepatic artery, also known as the common hepatic artery. S for the splenic artery. The largest branch is the splenic artery. Splenic artery we learned, no? It passes through which ligament? Splenic artery passes through the splenorenal ligament or the lienorenal ligament. Splenic artery. So left hand side is left gastric, hepatic artery and the splenic artery. Clear? Celiac trunk, foregut artery. Retropytonal structures. Now there are a lot of structures over here. Sad pucker is a mnemonic. Just go through it, read out the names over here. Right? What are these names? Just a second. Okay, yeah. S is the suprarenal gland, adrenal gland. Suprarenal gland. A is the aorta, D is duodenum. P is pancreas, U is ureter, C is colon. Not the whole colon, ascending and descending only. Kidneys. Right? E is the lower part of esophagus, I guess, and R is for the rectum. So these are some of the retroperitoneal structures. Now, not completely like colon, not complete colon is retroperitoneal, but a few parts of colon, like ascending and descending colons, they are retroperitoneal. Duodenum, majority of it is retroperitoneal, but excluding the first initial half of the first part of duodenum, the first, you can say, like 2 centimeters of duodenum, that is interperitoneal. Others. You can remember like aorta, IVC, kidneys, ureter, and kidneys, ureter, suprarenal gland, pancreas. These are mainly retroperitoneal structures and plus duodenum. Broad ligament. We discussed the gubernaculum remnants in females. What were those? Round ligament and ovarian ligament. Broad ligament contains the mnemonic is broad. That is the good part. What is BOB is the bundle, neurovascular bundle. So there are a couple of vessels like the uterine vessels and the ovarian vessels which run between the two-fold of peritoneum and the broad ligament. Round and ovarian ligament already have seen. Then the artifacts. Artifacts are these vestigial structures. Epiphoron, periphoron. Last year NEET PG they asked this question. Also in FMGE they have asked multiple times. Artifacts. And finally D is a duct, oviduct. What is oviduct? Fallopian tube. Fallopian tube is the content of broad ligament. Remember, ovaries are not a content of broad ligament. Ovaries are connected to the broad ligament via mesovarium. Mesoovarium. But ovaries are not a content of broad ligament. Right? So broad ligament contains the mnemonic is broad. Fine. So yes, these were the other few mnemonics and few one-liners which I wanted to share with you. So all the best for your exams, guys, and let me know how many questions came from here and how many of you guys are able to recall. So just go through this video again in fast mode and refresh and note the one-liners, and all the best for the exams, and be confident and relax and give your exams, and hopefully all will pass through it, right? Hoping to see you on the other side of the exam. Thank you and all the best.